Hello, everyone. I'm Dr. Patty Pellikka. I'm the editor-in-chief of Journal of the American Society of Echocardiography. Welcome to Author Spotlight. In this series, we feature the authors of one of the papers published in this month's issue of JASE. And I'm joined today by Dr. Christina Luong, who is Assistant Professor of Medicine at University of British Columbia, Department of Medicine, and Dr. Garvan Kane, who is Chair of the Division of Cardiovascular Ultrasound at Mayo Clinic. They have prepared a paper, Prognostic Significance of Elevated Left Ventricular Filling Pressures with Exercise, Insights from a Cohort of 14,338 patients. And Dr. Luong is the first author of the paper, and Dr. Kane, the senior author. Welcome, Christina and Garvan.
Thanks, Patty.
So, Garvan, tell us about the background, why this study was conducted.
Well, Patty, we've known for a long time, you and others have done over a long time, the value of exercise stress echocardiography for the diagnosis of myocardial ischemia. We are increasingly seeing patients with shortness of breath. Some studies suggest now more than half the patients coming to cardiac clinics are patients who are short of breath. And we can diagnose shortness of breath, or at least the cardiovascular explanations for shortness of breath, using echo in a whole variety of ways. We've known that dyspnea is a significant and potential anginal equivalent. You've known that for a long time. We know that if patients who are short of breath with exercise, they have a worse prognosis. But we know that even in the absence of epicardial coronary disease, they can do worse. And probably a lot of that is heart failure, or at least heart failure with preserved ejection fraction. We can diagnose valve disease, we can diagnose HFrEF really pretty easily on a rest echocardiogram. But at times we struggle with HFpEF on a rest echo, particularly in patients where their filling pressure is not elevated at rest. If they're grade 2, grade 3 diastolic function, it's relatively clear. But so often it's a patient who has grade 1 dysfunction or indeterminate findings at rest, and they only elevate their filling pressures when they go to exercise. And so a number of years ago, now over a decade ago, we incorporated a diastolic evaluation into our exercise stress echocardiogram, and we do that routinely in all patients who come to the lab. And so the point of this paper was to really look at a finding of elevated filling pressures with exercise and really understand the additive yield that has for our patients and what that meant for prognosis.
Thank you. It's certainly been a boon to our clinical practice. I think it helps us understand many of our patients and their symptoms, particularly of exertional dyspnea. Christina, tell us about what you found.
Right, absolutely. So as Dr. Kane already alluded to, this is a standard parameter that was being evaluated at the Mayo Clinic. And shown here on this central figure is on the left side is the expected pattern of response that you would expect for Doppler parameters in a normal and abnormal situation. So for normal patients who do not have elevated elevated filling pressure, you would expect a proportionate increase in mitral E as well as mitral E prime, which results in an E over E prime ratio that is similar to rest. Versus the abnormal situation where the mitral E will increase. However, the mitral E prime might not change very much, resulting in an elevated E over E prime ratio. And on the right side of this slide is the main result of our study, which demonstrates that patients with elevated E over E prime post-exercise, defined as an E over E prime of greater than or equal to 15, had a significantly higher risk of mortality compared to our reference, which was patients with E over E prime less than or equal to 8. And the reason for choosing an E over E prime value of 15 has to do with previous studies that demonstrate this as an established value that correlated with increased filling pressure on invasive hemodynamic parameters. And so the interesting thing that we noticed in the data is that in patients who have E over E prime values that are intermediate, so between 9 and 14, these patients also had increased mortality compared to reference. And so the the significance of E over E prime post-exercise is kind of a gradual or a gradual risk as opposed to a sharp cutoff. And so other figures in our paper demonstrate that the higher your E over E prime value is, the worse your prognosis. And so it's not a hard cutoff at 15, but certainly 15 was picked due to previous studies demonstrating its significance from a hemodynamic point of view.
Like an easy to obtain piece of data, this Doppler data adds a lot of information prognostically to our stress echo. I'd like to encourage all our viewers to read this interesting paper. Also, Dr. Stephen Sawada served as guest editor for this work and has written an excellent editorial that places it in context. Please read that too. Thank you for joining us, and thank you, Garvan and Christina.
Thanks very much.